So WellNet's a third-party administrator, a healthcare management company, if you will. We're a national boutique firm that helps our clients, our consultants, build healthcare plans from the ground up using networks, using reference-based pricing, using traditional PBMs, using fiduciary PBMs, whatever it is that you're looking to put together, we have the ability to do. We've got clients all over the country ranging from 25 employees upwards of 10,000 members. So we've got experience in all kinds of different industries, demographics, group sizes. The major issue with healthcare today is really that no one addresses the 800-pound elephant in the room, which is the cost of healthcare. And if you break down an insurance premium, whether it's a car insurance premium or a P&C premium, house insurance, whatever it is, most of that premium is made up of claims. And yet I watch the news and no one talks about claims. They talk about subsidies and how do we control the premium and what if we penalize this guy or incentivize this guy. But no one actually talks about the problem. The problem is the prices. Sure. There was an article put out, it said the problem is the prices, stupid. It's about the prices. How can we expect premiums to come down if we don't talk about the cost? And so whether you're fully insured or whether you're self-funded, claims represent, let's say, 80% of that. And in the fully insured market, due to the medical loss ratio, that is a fact. 80 or 85% of the premium paid is in the form of claims. So logically, then, it just makes sense. If we lower the cost of claims, we should lower the cost of insurance, right? Makes sense. The problem with that is, now let's apply that logic to either a fully insured plan or a self-insured plan. So on the left side of your screen, you've got a fully insured plan. Good news with a fully insured plan, it's budgetable. Pay the same amount every month. Bad news is your renewals go up every year, and when you say why, they say we don't tell you, sorry. More importantly, if you lower claims, it doesn't necessarily lower costs. And the reason is inside of a fully insured plan, the claims are pooled, right? Which could be good, it could be bad. If your people are utilizing more health care than the premium you're paying, that's good. If your people, on the other hand, are utilizing way less health care than the premium you're paying, you're probably better off being self-funded. So there is a benefit to being fully insured, but let's apply the concept of claim reduction inside of a self-funded plan. See, if you're self-funded in any capacity, whether it's level funded, traditionally self-funded, partially self-funded, whatever the term, there's a direct correlation, a 100% correlation between claim reduction and cost reduction, because you only pay for the health care your people consume. So if your people consume $1 less of health care, I just saved you $1. It's a direct correlation. And so if the collective objective of employers and consultants is to lower the cost of insurance or the total cost of everything, we've got to address the cost of claims. So in America, the biggest problem, as I mentioned, is prices. And so this slide that you see on your screen talks about the pricing problem. The prices are going up and up and up, while utilization has actually stayed pretty flat or gone down in many instances. If you look across the world in terms of industrialized countries, the United States has the highest price by far and not nearly the best quality. So we have a problem, but primarily it's driven by a complete lack of transparency, particularly on the price side, okay? So we've got to talk about prices. We're going to keep talking about that. Now, the national carrier solutions haven't worked. Most employers depend on, these national insurance conglomerates to manage their costs, but they don't want to talk about costs. That's the problem. They want to talk about how you control your premium, but they don't actually talk about the cost of care. Actually, that's quite a secret to them. The result is what you see on your screen. So on the right-hand side at the top, it shows 73% of total cost growth between premium and out-of-pocket expenses for a family of 4. The number under that is 69%, and that shows the employee out-of-pocket spending. And that's gone up 69% over the last 9 years. That's in the form of higher co-pays, higher deductibles. Then beneath that is 105% premium contribution growth from employees. And beneath that is a 62% employer premium contribution growth. All in all, the numbers at the bottom are the most startling to me. So in 2008, 8.1% of a family's income was spent on health care, whether that's in the form of premiums or out-of-pocket spending. In 2015, which is where the data ends on this slide here, it was 11.9%. It's probably worse today. What does that mean in different terms? People are making less money today than they were making in 2008, and it's a direct result of healthcare. And all we've done traditionally as consultants and advisors is shift cost. Higher deductibles, higher copays. The average American can't afford $1,000. I read an article a month ago, it said 39% of Americans could afford a $1,000 expense. Not a healthcare expense, just $1,000. And yet we keep putting them in these high deductible health plans. They can't afford it, and so they don't use the care. and the medical conditions just get worse and worse and worse, and then they end up in the ER, and that's not helping anyone. Now, there's two reasons that I'm going to talk about on this slide why a fully insured or a national insurance carrier is never going to try to control the cost of claims. First, I want to talk about the medical loss ratios. You know how they work, but basically, in simple terms, for a mid-market group, or on this slide, I'll use the small market, 80% of the premium charged by the national carrier for the whole book of business, 80% of that premium has to be claims. And so at the end of each year, they have to apply to the state insurance department for rate increases. And they have to prove to the state insurance department that 80% of that rate increase is going to be paid out in claims. So in really simple terms, there's a financial incentive to let the cost of claims go up. It's the only way the carrier can charge more premium. And these are publicly traded companies, which leads me to the second point. The fiduciary responsibility of a publicly traded company is to please shareholders and to drive revenue growth. But now if you connect the dots, the primary way to drive revenue growth as a national insurance carrier is higher premiums. But that can't go up unless claims go up. And so you have this whole system working against you. And an employer, particularly a self-funded employer, has their own fiduciary responsibility. Early 2017, WellNet drafted an article, and we pitched it to the Wall Street Journal, and on Halloween of last year it was published. And the title of it was The Deception Behind Those In-Network Health Discounts. And it talked all about how focusing on a discount, which is what the national carriers want you to focus on, is all smoke and mirrors. When you actually say, how much is this hospital going to charge, the answer is, we don't share that, but don't worry, you're getting a 55% plan-wide discount. What the hell? What good is that? You know, if you believe that's a good deal, I've got a Ferrari I can sell you for 90% off. How much is it? Well, don't worry about it. You're getting 90% off. You'd never buy that Ferrari, and we buy all of our health care under that same premise. If we want to lower the cost of insurance, we've got to lower the cost of care, right? One of the things that we found, and most people know this, but this slide helps articulate it better, is that every hospital and provider can charge whatever they want. And every hospital and doctor and provider and facility creates their own contract with a particular insurance company. So just pick an insurance company. That insurance company, generally speaking, is going to pay every single doctor a different amount for the same thing. So pick a knee surgery. In any market, there's usually a variance of somewhere between, let's say, 50% and 300% for the cost of a knee replacement. So if we know that, how are we not taking advantage of that? Well, self-funded employers can. So we happen to find a website. It's listed at the bottom of the slide. It's called Payer Compass, but it allows us to go into any market and show what hospitals are charging as a percentage of Medicare. So at the bottom of this slide, it's showing the key, so you can understand the points on the map. But at the top, this is the Nashville market. TriStar Skyline, on average, is charging somewhere between 582% over Medicare and 714% over Medicare. Vanderbilt Hospital, or let's say Nashville General here, is charging somewhere between 82% and 217% over Medicare. So in really simple terms, if we're going to play this discount shenanigans, which one of those facilities would generate a lower claim cost if we knew nothing else? Is it TriStar Skyline or is it Nashville General? Obviously, the answer is Nashville General. Now, the problem is we can't just focus on cost. But we're getting somewhere. Now we're getting down to the root of the problem. Because if you're self-funded, we can start to leverage this. If we're going to use the discounts, you might as well send people to the lower cost facility. But we can't do it without quality. Because the last thing I want to do is send someone to some hospital that's going to kill them from some infection or something terrible. So we found another resource called hospitalsafetygrade.org. It's another website that shows us hospital safety grades. And so what we found is that Nashville General turns out is a D rating. And if you've been to Nashville and ask around, people will say that is where you go to die. So you don't want to necessarily use that hospital, nor would I ever want to send someone there just because it's going to be cheaper. However, when you start to analyze the data, a pattern becomes clear. So it's about finding a high-quality facility that is also fairly priced. And so if we look at the quality here, I would suggest that Vanderbilt Hospital or TriStar Centennial are the better options, particularly when you take back into account the cost. So TriStar Centennial is priced better than TriStar Skyline, and the quality was better. The problem to start is that employees today, for the most part, have given up. Like many employers, they say, I don't care about anything, I just want my premium to stop going up. And that inherently is the problem. So a lot of this is education. It's helping them understand what we're talking about right now. and then showing them that there's an easier way. We would never expect them to have to do this research on their own. So WellNet partnered with a vendor that has, and I'll go into this in detail in just a moment, but that makes it very easy. It's a phone number. Members talk to a nurse. The nurse does all the research based on exactly what it is that the member needs, and the nurse will show the member different provider options, including the provider that the member wanted to see initially. And if they choose a provider that is of high enough quality and of low enough cost, we call those high-value providers, most employers are paying out some sort of incentive or maybe even waiving the deductible to keep it simple. Employees are never forced to do anything. They're still using a PPO network. It's just that we have a conversation. We say, if you help us and you're a smart consumer, we'll pay you to be that. So the way that WellNet manages the process of educating employees and steering them starts with that phone call to a nurse, okay? And it's a partner that we hired. That nurse uses their own proprietary software system based on volume and quality. First starts by understanding what you need. Then we look at how many of that particular procedure the provider has done, what are his quality outcomes. Then the nurse cross-references that with the cost metrics that they've got in their system, and they'll present back to you what they call a high-value network. Okay? Now the way that that is broken down, most of the people calling in, I'll get to the breakdown in just a moment, most of the people calling in call in for a medical or surgical referral, exactly what I'm saying right now. I heard I might be able to get an incentive, I need a wrist surgery, help me find a great surgeon at a fair price. Real simple. You have 23% of people calling in for medical coaching. That's like, my doctor said I have this, but he only saw me for 2 minutes, what am I supposed to do? This seems pretty important, but he wouldn't spend any more time with me, which is another problem with our healthcare system. 12% of people are calling in for primary care, and then, several other items less common. Here's the methodology by which our nurse is going to help a member identify a doctor or a provider. When the member calls in, the nurse answers the phone and basically says, how can we help you? Member says, I heard I might be able to get free care. I need a wrist surgery, specifically carpal tunnel surgery. What's the deal? The nurse is going to say, well, how far are you willing to travel? You might say 43 miles. She'll ask you a couple other feeder questions. What's most important to you in terms of finding a provider? So she wants to custom tailor this search for you. And then she's basically going to come back and say, okay, look, there's 60 people, this is on the right side of your screen, 60 providers within that 43-mile radius that fit from a market perspective inside of your specific PPO, that participate with your PPO. Only 14 have done enough procedures, which is 50 or more. If they've done less than 50 carpal tunnel surgeries, they're off the list. 50 or more. So there's only 14 that did that. Only 8 fit from a quality perspective, 6 from a cost perspective, and then only 4 when you wrap in other things like readmission rates, complication rates, malpractice lawsuits, all of that. And then it's up to the member. If you want to use these 4 that are in your radius of 43 miles, you'll earn your incentive or have that deductible waived. But it's up to you. You don't have to. Here's the quality metrics for the doctor you wanted to see. Feel free to see him. He's in your PPO. You'll just have your full cost sharing, whether that be a copay or a deductible. Here's a visual of an open heart surgery. If I'm the guy that's about to get my chest cracked open, now you got to put yourself in the view of a member. Today, no matter who you ask, you say, how are you going to find a heart surgeon? People say, well, I'll talk to my friends. I'll ask my doctor. I heard that, this hospital down the road does really good heart work. Well, that's just good marketing. Your doctor's probably owned by the hospital system. That's why he's sending you to his golf buddy up the street. And your friend, although that's good that they also had a good surgery, it's not based on anything other than that one experience. And so really the value that we're bringing is giving a member access to historic research before care. And we're talking about high-cost care here, number one, and life-changing care. If I'm about to get cracked open, I definitely, on the right side of my screen, don't want one of those doctors that have a higher than average death rate, or the ones up at the top that have a higher than average complication rate. What I want is a surgeon that's been vetted out, one that I'm comfortable with before I go in. And we don't force anyone to do anything, but the incentives help members to make that phone call, and at the very least, even if they don't follow the advice, at least they feel better about their own surgeon. Oh, well, he did 63 surgeries last year. You know what I mean? So WellNet on our PPO platforms, and I'll get to reference-based in just a moment, can offer either the Cigna or the Aetna networks. We can duplicate the existing plan designs that a group has. We can custom build one. We can use WellNet's canned plans, whatever it is that's right for your client. We then layer on a couple of cool cost-saving features. One is telemedicine. You can use your own vendor. You can use our vendor. Either way, we encourage that it's offered to the employees at no cost so that they use it. The second cool thing we're doing is that steerage idea. Doesn't matter what PPO you're in, knowing that there's such a huge cost variance and such a huge quality variance, to me, it's an absolute no-brainer to make that resource available to your people. And I don't know a single human being that wouldn't appreciate that benefit. And it's always going to save money in the long run and improve the predictability of outcomes, because at least there's a conversation about outcomes before you go in, okay? Then we do medical bill review. What most people don't know is that the national carriers prohibit auditing of claims. Your contracts, whether it's a fully insured contract or a ASO contract from a national carrier, says you can't audit claims. And furthermore, what makes it even worse is it says they can audit claims. And if they find they've made an overpayment, they get to keep 20 to 40% of it, whatever that contract says. Which incidentally reinforces the fact that they're trying to let claims costs go through the roof so they can keep raising premiums. You have to audit claims. And then we can change the out-of-network reimbursement away from UCR, which is unreasonable, crappy, and ridiculous, to a multiple of Medicare, which is a growing trend. So if you're not going to see a PPO doctor, at least the self-funded health plan pays that non-network physician a multiple of Medicare. Not at Medicare, that's a little low. Most people would agree, but higher than that. But not these crazy UCR prices that the carriers would have you believe is a good price. Then we can wrap on WellNet's full population health management, which is really a custom-built wellness program, health coaching, on-site, whatever it is that you can dream up, we can help you build from that perspective. So wellness means different things to different people. We refer to it as population health management because it truly is managing the health of a population. I'll never tell you that one specific wellness program is right for this client or all clients or whatever. It starts with us with the use of our software. So WellNet has our own proprietary software. We feed all of our claims into it in real time, and really at any point, any stakeholder, whether it's the client, the consultant, or WellNet's account management team, can pull those reports. There's predictive analytics built in. So it's pretty easy for me to, it might take me a couple minutes, but I can get back to you and say, look, here's all the medical conditions that people are suffering from. Here's how many people have high blood pressure, high cholesterol, type 2 diabetes. Here's how that benchmarks against the national average. Here's the predicted claims costs for all of these people. Here's the compliance rates for all of these people based on their medical claims they're incurring, the drug claims they're incurring. And that becomes pretty insightful. So now we're all sitting around the table saying, wait a minute, that looks off. Well, this looks off. That looks off. And now we build a wellness program that's specifically catered to that group. That might include biometric screenings and health risk assessments. It might not. I don't know. Maybe we should do on-site coaching for cardiovascular health if everyone's got those problems, or type 2 diabetes training, or waiving cost sharing for diabetic supplies. It's all relative to the data. Okay. On the pharmacy side, WellNet's doing really three cool things that they're not so cutting edge to us, but for most people it's cutting edge. The first is international mail order. If you do some research on drugs, you know that internationally sold drugs, same manufacturer, same bubble wrap, are considerably cheaper than drugs in America for lots of reasons that we won't get into today. So we're talking about potentially 60 to 70% savings on all drugs we can source internationally. It's a pretty easy process. We look at what drugs people are taking, we look at what drugs we can source internationally, and many employers choose to waive all cost sharing for employees that allow the drugs to be filled internationally. And we proactively outreach to the members and offer them that incentive of no copays. Most accept it. And then everything we do is all accessed through all of WellNet's software. So our consultants get a portal, our members get a portal, we get a portal, so it's very easy for all stakeholders at all times to understand what's happening. Now, you asked a moment ago about reference-based pricing. It's very simple. So reference-based pricing is the idea of, it's a privilege, really. Self-funded clients have a privilege. They can change the plan document language so that there's no more network, and they name their own price, like Priceline, okay? It basically changes the plan document to say, I'm just going to make this up as an example, we pay all providers Medicare plus 50%. The term reference-based pricing means basing your pricing on a point of reference. The most commonly used reference is Medicare, because they're the biggest payer, number one, in the United States. And two, they publish their prices. We could leave here today and you could Google Medicare colonoscopy cost. It might take you a little while, but you'll find exactly what Medicare pays for colonoscopies. So if you're a self-funded employer and you change your plan document to read, we pay all providers Medicare plus 50%, now you know exactly what you're going to spend on your health care. It makes the costs not only rational because you're pricing it from bottom up, you know what the price is, and you're paying doctors even more than what they get from the government, and it's predictable. The contrary, what most employers are doing today is basing their final payment to a doctor on whatever the carrier says that the negotiated rate is. You don't know in advance. The doctor bills this, but you get a discount. We don't even tell you what they bill until you see the EOB 6 weeks later. That's completely irrational, and it results in completely unpredictable claims costs. And it really boils down to that hospital grid I showed you. If an employee goes here for a surgery versus here, and all we're doing is blind discounts off of a billed charge, then clearly going to this one's going to cost way more than going to this one. So reference-based pricing allows you to name your own price, and then really all you have to worry about is how you educate employees and how you help them find quality doctors. It's really the same idea as we were talking about on the PPO plan, just applying it now inside of a reference-based plan. I'll get into a little bit more detail here. So here's what WellNet's reference-based plan design looks like. Basically, there's no network anymore because you just changed the plan document. We don't need a network. We're paying all doctors a fair and equitable rate, which incidentally is important. If you pay a doctor right at Medicare, he's going to say this isn't enough. If you pay them 400% over Medicare, they'll be bowling over everyone to get your money because that's a lot of money. But that's too much money. It's more like what you're paying now with the PPOs. So the idea with reference-based pricing is setting it high enough that the providers like it, but low enough that your employer not only saves money, but feels good about what they're spending. People are okay spending their money, but they want value for their money. They don't want to get ripped off. Reference-based pricing enables that. The member's experience really doesn't have to be too much different. The plan design can be exactly the same as the PPO plan. Okay, so we do exactly the same copays, same deductibles, et cetera. We can layer on the telemedicine just like we did with the PPO plan. And now there's different ways that third-party administrators set up their reference-based plans, and no two are the same. There's two key objections that come up with reference-based pricing. The first is, what if the doctors don't take it because there's no more network? We kind of address that with the equitable payment and also heavy employee education. We need mandatory employee meetings before we sell a reference-based platform because we need employees to understand how healthcare works and everything else. The other major objection is balanced bills. Now, when WellNet set out to build our reference-based health plan, one of the keys for us was being able to offer employees a national network of providers that have already agreed to accept reference-based pricing. We looked long and hard for that, but we found a partner that has a network of over 700,000 primary care docs and specialists and over 2,000 facilities. That means there's plenty in every area. Now, because there's no network, employees can go anywhere they want, and they're educated what to expect when that happens. Most doctors are not used to that. So if the doctor's not already part of that network, they might push back a little bit. But we've been through it. We understand. We understand how to educate the employee. We understand what to do when the doctor says that. We have a game plan for that, and the employee knows that in advance. To make it really easy, though, many employers incentivize people to use that network of already pre-negotiated providers. Number one, because it's easy. We'll do all the appointment setting. All they have to do is call that phone number, just like the PPO plan. Call the nurse. The nurse will help you understand quality. They'll help you understand what doctors have already agreed to accept it. And if you say, I don't care about that, I want to go to my doctor up the street, the nurse will tell you about that. She'll say, here's the quality of that doc. Just remember, he hasn't already agreed to reference-based pricing, so here's the things he might say to you. If that happens, remember what your training was. Okay, remember how we told you to deal with that. The other concern, aside from will a doctor accept it, is what about balanced billing? Some of our competitors have taken this upon themselves, and when you ask them about balanced billing, they say, don't worry about it, we take care of it. That's okay, that's an approach. But this being a relatively new concept for most, it was our approach that we should find someone that's been doing this for quite a while. And the partner that we found has been doing medical bill review, i.e. auditing, and also balanced bill defense for many years. And so they have a 3-tiered legal defense system. So what that means is if a member ever gets a bill that looks funky from a doctor, because when there's no network, a doctor can bill whatever they want. So if that ever happens, which incidentally is only 2% of bills, okay, then member calls the phone number on their card for balance bills, and they are asked to sign a legal affidavit and a HIPAA release, and our vendor now becomes the legal representative for this person. And at first, a paralegal, this is the first step, sends a letter to the hospital saying, please cease and desist all collection efforts. We're appealing this claim. Please communicate directly with us. We're John's representative. And furthermore, we've paid you 50% of our Medicare in this example. We know you treat Medicare patients. This is more than fair. Our vendor sends a letter from an attorney this time, a little more strongly worded, but basically the same thing. Here's why we paid you what we paid you. It's more than fair. Please accept it as payment in full. If it gets appealed a third time, we have on retainer one of the nation's most prominent healthcare attorneys that will then send a letter back, basically very strongly worded at this point. And to put it in very simple terms, the vendor that we're using has never, ever gone to court. We always settle. That's important because other vendors that have put together these reference-based plans brag about how many lawsuits they've been in and how many they've won. They've won all of them, which is good. It's good because it proves how we're effectively doing what we're doing. We're just negotiating and avoiding the lawsuit. You could take the tack that I'd rather sue because it'll keep my claims down, and that's okay. Technically, we could do it that way. But we've all internally and with our partners agreed that the better way to do it is to negotiate. It might result in a slightly higher claim cost at the end of the day, but it's way less noise for anyone. No one wants to be in a lawsuit. It is important to note that our vendor on this acts as a co-fiduciary, and so does WellNet, which is a question worth asking, because many are not co-fiduciaries. We can still wrap this with population health. We can still do the pharmacy stuff I talked about before to help control that. And again, this is all tied together as well. Now, one cool thing about WellNet is that to the same group at the same time, we can offer both our PPO platform and our reference-based platform, provided we have 25 enrolled in each plan. So typically that's for larger groups, but it takes away that objection of we're not ready for this. Of course you are. What's interesting is that when I have this conversation with an end user, my friends, my family, and we talk about reference-based pricing and the logic behind it and how it's basically just negotiating in advance of care and finding high-quality docs, it's a no-brainer. Now, it requires education because, again, most people are like, I don't care, I just don't want my premium to go up. So first they have to understand how the premium is going up. And once they understand that, it becomes starkly obvious that we have to start doing things this way. We have to talk about cost and quality. Now, I talked about those two objections. We've put this on a slide for you guys so you can go through this. But effectively, it's paying providers an equitable amount up front. That will increase the odds that most will take it. It's giving members the option of a national network of docs that have already agreed to pre-negotiated payments. And then it's about helping members defend against a balanced bill. Obviously, if we incentivize members to stay within that reference-based network, there are no balanced bills. If we educate them in advance about how to communicate with their doctors, there's less balanced bills. So all of it really boils down to education and how you set the plans up. So most providers today, I'm going to talk primary care doctors right now. If you look at the reimbursements that they're getting from the national carriers after discounts, it's usually less than 50% over Medicare. So if you think about what we said, we're talking about paying a doctor 50% over Medicare, which is more than what they're getting in most cases from the national carriers after the discounts. The only challenge is reference-based pricing is new to a doctor. So on the surface, they don't know what it is. And so it requires education. This is all about education, but it's also all about common sense. If we can pay a doctor a fair rate, and he doesn't have to deal with an insurance company, for example, he'll be happy to do that. It's more time he can spend with patients. He's still getting paid for his services. And again, the member, because they're educated, their premium's not going up every year. That's key. And they're also getting quality care, at least more predictable quality, because they're talking about that before they go to the doctor with our nurses. So WellNet, like I said, has a whole suite of software. So we have predictive modeling. We have any of the standard reports you get from a self-funded plan. Whatever it is you want to see, we will share it with you. Now, what does all this mean, right? So one of WellNet's clients is a car dealership with over 600 employees, and we worked with their agent to put together a 2-year savings projection. We looked at where they were with Blue Cross. They were with Blue Cross about 18 years, and where the renewal came in, then where our maximum costs under a self-funded plan came in. So they couldn't do any worse based on the stop-loss coverages. But that's just the worst case scenario, where they actually performed, meaning because you only pay for the health care that they consume. And in a level funded plan, we gave them a surplus check at the end of the year. That's how that worked. So 2 years, we gave them big surplus checks. And if you compared where they actually performed versus where the market was saying their fully insured rates would have been had they stayed fully insured, it was over a $4 million savings. And what's interesting about really everything we're talking about is you have the opportunity to get a client to rethink how they view healthcare. If you view healthcare the way, if a CFO views healthcare the way he views every other aspect of their business, it's about managing the supply chain. If you're a car dealer, where am I getting my parts? Where am I getting all these things that go into my dealership? And how do I run that more efficiently? You're managing the supply chain. That's all I'm actually talking about. In healthcare, there's a supply chain. Doctors, drugs, surgeries, all these things add up to your premium. And if you're not going to control them, then good luck controlling your premium. And so at the end of the day, it really boils down to the slide that you see here. This car dealership, by managing their health care plan better, sold the equivalent of 4,000 cars. Their average profit was about $1,000 a car. And so when you start thinking about healthcare in those terms, lower cost, the unit cost, improve quality, it changes your whole perspective on things. Healthcare is not this unwieldy beast. It can be controlled. It's time that all of us grab the CFO back into the conversation and say, we can control this. But you need to think outside the box a little bit. You can't keep doing the same thing and expect a different result. On the left side of the screen represents what I'll call the status quo agent. Okay, they go into their clients, they say, we got you negotiated down to an 8%, you started at 22%, you budgeted at 10%, sign here, we'll deal with it next year, okay? But that's resulting in this unsustainable trend line, which is why we're all having this conversation. On the right-hand side of the screen, that new consultant is saying, hogwash with that stuff. Let's focus on the supply chain. If we control what we can control, I can get your trend to stop or reduce. The right side of the screen is the future. And so here's a challenge. Imagine being able to sit in front of a client and for the first time stop the nonsense. It's no more to get your premium to stay flat, you got to swap spit with another carrier, or you got to raise deductibles and cost sharing. It's about using these common sense solutions to improve the cost. That's all it is. In 1963, Martin Luther King had a dream, but all he was fighting against was bad thinking and just stubborn people, okay? WellNet had a dream. We built the dream that we saw, and we talked about it today. But we're not just fighting old thinking and old habits. We're fighting a whole system that has financial incentives against us in every capacity. The insurance companies have a financial incentive to raise the claims. The PBMs don't want you to know what anything costs. Most consultants today get paid a percentage of premium. So literally every element of the business, every stakeholder except the employer, has a reason to keep things exactly the way they are. And so we need people to really step outside of that and say, how do we build a better health plan? The modern, I won't say modern, the more progressive consultants are doing performance-based compensation. They're saying, look, I know what you're paying your consultant today. I might even charge you a little bit less. But if I hit these performance metrics, which we'll both agree on up front, I want you to end up paying me a bonus here, and if I really do what I say I'm going to do, a bonus here, and I'm going to get paid twice what you paid your agent last year. And if that happens, I'm happy to renegotiate my contract, right? So I would just say join us. Join the movement. Join the revolution. Help us deliver better health care to our friends and our family and ultimately for a better America. Thank you.